So usually journal clubs are a little more interactive, so kind of trying to figure out how to do it virtual and with slides is was interesting. But so I just tried to pick some of the key points of the 3 papers as we go through. So feel free if you have comments or questions as we go along to bring those up. And just as we're going through, with all of the information that's out there, and especially now with so much available online, as John Nesbitt said, you're drowning in information but starved for knowledge. So some of what we're trying to figure out as you're going through your articles and looking at journals is figuring out what you should be reading and kind of being methodical and going through those articles and analyzing them. So kind of why do we read journal articles? There's several reasons. Mostly it's to keep up to date, or for a lot of what we're doing is keeping up to date with progress in your particular field or specialty, areas of interest. Other times, especially for you guys in medical school, and then as you transition into residency, it's looking up information on a specific problem, trying to find answers to a question, or looking for more information about a disease process or its pathophysiology. As you get into research years, you're reading journals to try and come up with new ideas or new areas of interest for research. And then, as always, there's stuff that's assigned, like tonight, your journal club. And then you can read articles that are validating your own views and beliefs and gathering more information. And sometimes it's just to have the knowledge base to impress other people as you go on to your rotations. Really what we're hoping you're doing is continuing to read and learn more about neurosurgery in general and different diseases as you go through your training. As you're looking at articles or looking for information, there are different types of articles that are good for specific purposes. If you're looking at sort of research or more in-depth, you want to have your randomized controlled trials, clinical trials, experimental studies, or basic science research that relates to clinical translation. And then if you're looking at a lot of the diagnosis, therapy, prognosis papers, those are more reviews, textbooks, case series, case reports, and then topic overviews or sort of general information and updates can be systematic reviews. You'll see a lot of meta-analysis or collection of case series and case reports that are then all bundled together. And those can be good to get a general idea and basic knowledge about a topic. So the first paper that we're looking at is from the Lancet, and it is in that last category of topic overviews. So it's a systematic review, which will give us a good background. So as we're going through and reading articles, what you want to ask are kind of, what's the type of article? What's the question? Why did they do this study? How did they do it? What are the key findings? And then did they answer the question that they posed at the beginning? What was their interpretation of the conclusions? And then always, 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 as you're going through, what are strengths and weaknesses of the articles? What were the limitations of how their study was performed? So always have that in the back of your mind. And then as you finish reading the article, think about, is there something you can extrapolate from this? Are there other questions you can pose from the information that you got? So like I said, the first paper we're going to look at is the hydrocephalus in children, which is a narrative review and gives you a good background on hydrocephalus and kind of ties in with the first 2 lectures you've had in this series. The second paper looks at a randomized controlled trial that ties into endoscopic treatment versus shunting, specifically in Uganda. And then the last paper is a retrospective review using an administrative database that I did looking at ETVs and shunts in infants. And so all three of them are giving you a different perspective in this same topic of hydrocephalus. So when we look at this first article, it really goes in depth in the epidemiology, pathophysiology, causes, clinical presentations, treatment, complications, outcomes, future areas of interest in research in hydrocephalus, and gives sort of updates of where we are and all of that. And if you look at the end of that article, there's 142 references. And so that's something else. As you're reading articles, you can then use those references as a way to look into more in-depth learning. And the way that Dr. Worf and Kulkarni did this systematic review was searching PubMed and Cochrane and Embase for the keywords hydrocephalus or hydrocephalic, and kind of tied in the subsections of each area of hydrocephalus. What you can see from this article and from your last couple of lectures is there really is a broad definition and cause of the different ways we categorize hydrocephalus, both acquired and congenital, communicating and obstructive. And those different categories have a very diverse number of potential causes and a wide variety of proposed mechanisms of how those causes lead to the development of hydrocephalus. There also is a good discussion of some of the genetic abnormalities that can be associated with pediatric hydrocephalus. The X-linked hydrocephalus with aqueductal stenosis is linked with the L1 CAM, which is a membrane protein adhesion defect, and that accounts for about 10% of all of the hydrocephalus in males. And then there's a variety of other genetic links that are coming up with hydrocephalus. One of the other interesting things in this Lancet article, as you look at the first figure, there are some pictures both of congenital aqueductal stenosis before and after treatment. And in that figure D, I just wanted to point out these little areas where you see the reddish staining are areas where in post-infectious and post-hemorrhagic hydrocephalus, you see some of those hemosiderin staining along the walls of the ependema. So even if you don't know what an infant's initial cause of hydrocephalus is, if you see those changes in the ependema, you know there's been some sort of inflammatory process that's contributed to the hydrocephalus. In all of these papers, we're looking at ETV versus shunt in these infants. There are pros and cons to both of these procedures. And what you can see is, although at 1 year, the failure-free survival for a shunt is better than that of ETV, as you get out into 5 or 10 years, the children that have had success with the ETV then have a similar or potentially even a better long-term success with that. But at least in infancy, we still see that shunting has an overall initial better chance of success in that first year. And this next area that they're looking at in figure 4, they talk about the hazard ratio for ETV failure compared to shunt failure. And what this is looking at a hazard ratio, looks at what is the risk of failure of one group versus another. And so this little dividing line here at 1, if you have a hazard ratio of 1, an ETV has a higher chance of success or a lower failure risk. And if we're looking at a hazard ratio in this area above 1, that shows that the shunt has a higher success rate. So you can see in those first 3 to 6 months, a shunt has a better success, but then those lines start to drop off. And these were the dotted line. If you look in the description for that figure, the dotted line is for all patients, and then the solid line adjusts for propensity, and so equalizes the 2 sets of patients. But it's important as you're going through all of your articles, just look into the statistics, think about what statistics they're using, and do those make sense, and really look at what questions they're asking and what statistics they're using to analyze those results. When they get a little further into this paper, they go on to talk more about complications with shunts, complications with endoscopic treatment. And I know we've touched on those in the last couple of lectures. And some of the long-term clinical outcomes, as I just mentioned from figure 4, but then kind of looking into the last few paragraphs, they're talking about controversies and uncertainties. It's still a topic of debate on what the best treatment is for hydrocephalus in infants. There's shunt versus endoscopy. In infants under the age of 1, there has been data that shows that adding choroid plexus cauterization to those to that procedure does improve the success rate for ETV. And if you look, there's a couple of different apps that'll have that for you. I'm trying to find it on my phone. But there's an ETV success score that you can look at that goes through the risk of that contribute to ETV failure. Shunts are sort of the gold standard for treatment, but they have their own set of complications, and especially in certain areas, the risk of shunts can outweigh the potential downsides of endoscopy. And that's some of what we'll talk about in the next paper when you're looking at a resource poor area like Uganda. There are definitely some pros to endoscopy as opposed to having hardware that can have mechanical failures. Then talk
a question from a student. Would now be a good time to field some questions?
Yes.
All right, so this question, we're gonna go ahead, John Ernesto, and I'm gonna give you the option, the ability to turn your microphone on and talk to Dr. Jernigan.
Okay, can you hear me now?
Yes, sir.
Yeah, thank you all for organizing this. And Dr. Sara, I was wondering if there is a success score for shunt, because as you mentioned, there's one for the ETV, but I was kind of asking if there is one for BP shunt.
So there is not a success score for the shunt, but what you do see is that shunts have, because it's a mechanical device, it doesn't depend as much on the pathophysiology and sort of intraventricular anatomy. So the things that cause problems with ETV is the type of cause of hydrocephalus. So if you have an aqueductal stenosis that is just a simple single area of obstruction, those patients do much better with an ETV as opposed to patients that have had infection or hemorrhage where you have inflammation. For shunts, it doesn't matter the type of hydrocephalus that you have. Your failure rate with shunts is sort of a mechanical device failure. So regardless of the type of hydrocephalus, your shunt failure rate is pretty much set. And it's in that first year, it's about a 30% failure rate. And then, or 20 to 30% failure rate, we say half of shunts will have some sort of mechanical failure within 3 to 5 years, depending on which paper you're looking at. And
Oh, I see.
So.
Thank you for your answer.
Any other questions? Okay. So I think some of the other stuff that they talked about, or that Ben talked about in some of the updated things, is sort of figuring out when is hydrocephalus well treated. And that's another area of debate where we're looking at imaging, and as we're doing more endoscopy, more people are willing to have children with slightly larger ventricles, as opposed to with shunts. You may see smaller ventricles, but it doesn't seem to impact the children's cognitive development. But there's still a lot more long-term follow-up that we need to do, because we're just starting to collect data on these kids as they're getting into sort of several years out from the bigger databases with the hydrocephalus network or with some of Ben Worf's work in Uganda. So I think that's still a question of how much of an importance do we place on imaging and on just ventricular size as being a measure of success. They're looking at different types of radiographic imaging that may help us get a better idea of some of the elasticity of the ventricular walls, or diffusion tensor imaging that may help us from an imaging standpoint determine when we've actually adequately treated hydrocephalus. The other sort of areas that they're updating, shunts have been very similar mechanical devices since they were invented. And so really in over 50 years, there has not been a lot of advances in some of the technical and mechanical parts of the shunt hardware. And so they are looking at changing from just a programmable valve to developing more smart shunt valves that can adjust flow and demand depending on the actual real-time dynamics in the spinal fluid space. And there are also reservoirs that can provide continuous monitoring of intracranial pressures, which can be helpful as a surgeon for you to evaluate whether or not a child with headaches is just having a headache, or are they having an actual shunt problem. So those are some of the areas that we're looking into, and there's still a lot more basic science research going into the pathophysiology of hydrocephalus and where it's all coming from, And, you know, as we saw from the beginning, there's a huge list of different causes and different genetic mutations that can impact CSF flow and pulsations and lead to that pathophysiology of hydrocephalus. So I thought this article just gave you guys a good sort of overview and something to reference back to if you're moving forward and looking into hydrocephalus again. Taryn, do you have a question?
Yes, could you hear me?
Yes.
I was just wondering what, if any, are some of the long-term consequences of a choroid plexus cauterization?
So we don't think there's any long-term complication from it. You aren't cauterizing all of the choroid plexus. So when you're going in to the ventricle, you are in the lateral ventricle and you cauterize that choroid plexus basically from the foramen of Monroe back to the glomus at the atrium of the lateral ventricle. And if you have a flexible endoscope, you can then curve from the atrium down into the temporal horn and get most of that choroid plexus. But even if you're coagulating 80–90% of the choroid plexus that you can see within the lateral ventricles, there's still choroid plexus in the third ventricle and in the fourth ventricle that are contributing to CSF production. And then some of the CSF production is actually, you know, from the brain parenchyma and ependymma itself, as opposed to through the choroid plexus.
Okay, great, thank you.
Anything else? Anybody have any thoughts or comments? Okay. So then the second paper sort of takes us in another direction. And this is looking at endoscopic treatment versus shunting, specifically in Uganda. And so I think this is an area of research that's developing. A lot of the majority of the hydrocephalus in the world is actually post-infectious hydrocephalus in developing countries. And so the challenges there are a little different in resource-limited locations than what we have taking care of our patients in the United States. So there are some different pros and cons into how you're approaching hydrocephalus treatment there. This paper was actually a randomized controlled study and was in Uganda at a hospital and its affiliates to evaluate the one-year outcome of ETV with choroid plexus cauterization versus shunt, specifically for post-infectious hydrocephalus. They did look at cognitive scores as well as treatment failure and brain and CSF volume on CTs as their secondary outcomes. And they divided the patients into two groups and did a randomized controlled study. So it was a very methodically planned out study. They had 158 patients that were assessed for eligibility. Two neurosurgeons evaluated every patient that came in with hydrocephalus and decided whether or not they were appropriate. Kind of important to go back and look at inclusion versus exclusion criteria. The inclusion criteria, the children all had to be under 6 months of age at the time of their treatment and have post-infectious hydrocephalus, but no active evidence of CSF infection. Their mothers all had to be over 18, and they had some geographic restrictions so that they could make sure that children were able to access follow-up care. The other exclusion criteria were, besides an active CSF infection, were significant congenital brain anomalies or multiloculated hydrocephalus. And those exclusion criteria are things that would steer you away from endoscopic treatment because they would make it much less likely that an ETV with or without CPC would be successful in treating that. So those kids were put into a shunt only category. They didn't have the option of both types of treatment. So 100 kids underwent, or infants underwent, randomization, and it ended up 51 were designated to get ETV CPC, but of those 9 went on to get a shunt, and 49 were assigned to shunt, and 1 actually ended up getting an ETV. So there was some crossover, but it was pretty minimal from their intention to treat, which is what they were designated to do, versus what they ended up getting. In both groups, they had several patients that died before the 12-month follow-up, and that's not uncommon in developing countries to have that sort of mortality associated with infant hydrocephalus. So in both groups, they ended up with 47 children in their final analysis. So another thing is, you're looking at papers that's important to think about is the statistical analysis and whether there's enough power to figure out your primary outcome. So just, they mentioned it specifically in their statistical analysis portion of the methods. They planned for the fact that they would lose some patients to loss of follow-up or death. And before they started their study, they worked with the statistician to figure out what the power of the study, or how many patients they needed to have in the study to evaluate their primary outcome. And when you're going into research projects, you should always look at that and work with your statistician from the get-go to figure out whether or not you can collect enough patients to get to the answer of the question, whether it's whether you validate your research question or not. Are you powered enough to actually get a good statistical analysis of that? So sort of referencing back what John was asking about shunt success. So this talks about failure-free survival. So at 1 year, 75% of the shunts were still working. So the kids that had shunts, 3/4 of them were doing well and did not need any additional surgery. On the other side, the kids that got ETV CPC, about 2/3 of them had continued to do well and didn't need additional surgery. And that's probably for children under the age of 6 months at the time of their initial treatment. I think a slightly better ETV success score than what you may see in some other centers' results. But still, again, sort of showing, at least in that first year, shunts have a better initial survival, but because over the lifespan of children, you need multiple revisions. If kids can have their hydrocephalus treated with ETV or ETV CPC, then they likely will need fewer surgeries over their lifespan. This article, or this figure is looking at the brain volume between the two groups. And this sort of references back what was in the general article of talking about the question that we're trying to figure out both with spina bifida patients, and in this case, post-infectious hydrocephalus patients, and some of our congenital hydrocephalus patients. Do we need to aggressively treat children that still have mild ventriculomegaly, or can we let kids have slightly bigger ventricles with endoscopic treatment and still not impact their long-term cognitive development? And for both groups, they split it into gender, so it's female and male. You can really see in both groups that the numbers are sort of all over the place. The blue lines are the shunt and the orange lines are the endoscopic treatment, but those lines are all interwoven. So there's no difference in the median or final brain volume for the VP shunt group versus the ETV CPC shunt group. And there is no difference in the female versus male patients. One thing to note, so 90% had 90% had significantly low brain volumes, but then by the time they got to 1 year out, only 75% of them had significantly below average brain volumes. And then another thing that they started to do in this article, and then there are some more updated information from the HCRN, the Hydrocephalus Research Network, that are starting to look at Bailey scores, which are a way to look at childhood development and whether you're meeting developmental milestones. It's especially in a 1-year-old, and if you start to think about where 1-year-olds are and what they're doing, there's still a lot of cognitive development that happens after that first year. So the Bailey score for kids in this age group are pretty limited for us to evaluate. They did have decreased Bailey scores, so and lower scores is worse, higher scores is better. And so they are definitely on the below average or low Bailey score functions across the board. And that just points to the sort of overarching brain injury that these kids are suffering because of that meningitis and severe brain infection that's contributed to their hydrocephalus diagnosis. So sort of what they found was there's no difference in cognitive development, at least at 1 year, but that all of the children had overall poor developmental scores. So it didn't matter whether you were treated with a shunt or with ETV, that the children's cognitive and developmental milestones were impacted more from the overall brain injury from that severe infection as opposed to the treatment of their hydrocephalus. They talked about the complications for their patients, and I didn't bring any of that up, but that they didn't see any increased risk of morbidity or mortality between the two treatments. They did have several children in both groups die, and some of that's resource availability in developing countries. One of the other notes that the authors made is they do use the flexible endoscope, which allows you to get 80–90% of that lateral ventricle choroid plexus cauterization. And with a rigid endoscope, you cannot get all the way back into the temporal horn. And so their results with ETV CPC success may not be generalizable to other practices depending on what their technique is. Although there was a slightly better success with shunts at 1 year, it wasn't a significant difference. And I saw somebody has a question.
Yes, hello.
Hi.
Yeah, so my question's about the study, this particular study, it excluded active CSF infected patients. So I was quite curious what would be the management for such patients with active CSF infection. Would they still go for ETV or permanent shunting, or would they go for something like temporary external drain or ventricular subgaleal shunting?
So because this was done in Uganda, those infants with active CSF infections were treated with antibiotics, but they did not place external ventricular drains or do subgaleal shunts. So they just let them develop permissive macrocephaly to help compensate for their hydrocephalus. So that's, okay. It's a limitation of there are not the hospital resources to allow for those kids to stay in the hospital with an external drain in place. And so while they do get antibiotic treatment, you just let the children develop macrocephaly.
So you would have to wait for the pharmacological treatment to kick in before you go for a surgical intervention.
Yes.
Okay, perfect. All right, thank you.
We have another question in the Q&A feature, if you see that there.
Yeah, I saw something pop up. So, and someone was asking about steroids to help prevent arachnoid villi scarring with the inflammation. And that's a good question. There is not data one way or another. There is research going on into the pro-inflammatory response with infections to see if we can decrease the need for hydrocephalus treatment, if we can do that. Different people also have sort of pros and cons on whether they use steroids immediately after ETV to help decrease post-surgical inflammation and try and keep that ostomy open. There's no data though for meningitis that steroids decreases your risk of developing hydrocephalus. Anything else? No. So that, I think that was, is that the same QA? Okay, yeah. And so this is just an interesting article. I think it touches on some of the challenges on treating hydrocephalus in developing countries. And like I said, that's actually across the world where most of the most of the hydrocephalus treatment is ongoing in developing countries. And I've done a lot of volunteer work in Haiti, which is similar to Uganda, where you have, and the DR, where you have some of those resource challenges as far as patients and families being able to actually get to the hospital. And so whether it's better to have children with sort of a slightly permissive macrocephaly, so you're letting their heads be a little larger than average, even if that means that you can treat them with endoscopy as opposed to a shunt, which has a mechanical device and a higher risk of failure. And then Brian had a question, I think.
Yep.
Okay.
Hi, Dr. Jernigan. I had a quick question. In a resource poor area, I know you mentioned keeping it permissive for enlarged ventricles, but what about a possible, like a drug-eluting stent that could be placed, kind of like they do in cardiology? I'm not sure if that's under current research or not, or if that's possible.
Yeah, so they're looking at some of the same type of drug-eluting stents to use those in the ventricular catheters and shunts. Most of the time with the ETV, if you can get a good opening of that, it often stays open. Usually the problem that you get with ETVs after inflammation is not so much the opening you're making in the floor of the third ventricle, but sort of referencing back the other question about the inflammation and scarring, you'll see there's a lot of scarring throughout the subarachnoid space. And infants don't have as well developed arachnoid granulations, and so they aren't able to reabsorb their spinal fluid as efficiently as a little bit older children are. So you kind of get a two-hit for why they struggle with their hydrocephalus.
Thank you.
Anything else? Okay. And so then, the last paper is looking at, VP shunt versus ETV in infants under the age of 1. And this is a paper that I wrote using an administrative database. And so some of what we can talk about is sort of the benefits of an administrative database, but also what some of those limitations are. So like I said, it's a retrospective review. We collected 5 years of data from Pediatric Hospital Association. And so using that administrative database allowed us to have a large patient population. So we had 5,400 patients under the age of 1 at the time of their initial treatment. And we had follow-up of at least 12 months and up to 60 months for those patients. And the administrative database I used was the FIS hospital database. Boston Children's is a member of this database, and it's 39. I think it's actually a few more now, but Children's Hospital Association hospitals sort of across the country, and all of them contribute their ICD-9 codes, and you can get demographic data and readmission data and anything that's coded within that ICD-9 procedural code or diagnosis codes. So it's great in that you're getting a broad spectrum of patients from across the country. The limitation is sort of what information you're really able to pull from the coding data that's there. And so sort of already talked about that. There's administrative databases that are available. The other pediatric one is NSQIP, and there's, or I guess it's PD-NSQIP, and then there's also NSQIP and some other adult administrative databases available. So, like I said, you can only use sort of demographic variables that are collected. It's retrospective, so you can't choose what information's collected. You can only gather information from what the hospitals are submitting. And then if there are procedures that do not have an ICD-9 or 10 procedure code, or if you have sort of subtle subcategorization of treatments or clinical diagnoses, and they're all lumped together, there's no way that you can tease that information out from these databases. So sort of the biggest take-home message from all of this information is the difference in taking care of kids under 3 months of age versus the 3 to 12 months. So when we did a hierarchical regression analysis and sort of tried to find the cutoff for when that point was where we had a better and worse cutoff, it was right at this 90 days. So you can see whether we were doing a shunt or an ETV, if the kids were older than 3 months when we did that first hydrocephalus treatment, they had a much better chance of overall success with that initial treatment. And the groups were pretty evenly matched with both gender, race, and their diagnosis. And sort of makes sense that if it was a hydrocephalus related to prematurity, IVH, or spina bifida, that those patients did worse than the sort of congenital hydrocephalus patients. And this is just a graphing to look at whether there was any benefit to high volume institutions versus low volume institutions. And so in a lot of other surgical specialties, you'll see that in high volume institutions, they have a much lower complication rate or better success with the procedures that they're doing over and over and over again. And we did not find that for either shunts or ETVs. And I saw somebody had a question. Oh, so looking at the 1 year failure. So we actually looked at not just 1 year failure for the patients that we were following out over that 5 years. We monitored them throughout that 5 years. The 1 year failure, we chose as our minimum follow-up because most of the ETV failures are going to happen in that first 6 months. And then usually if you have an ETV failure, by the time you get a year out, you will have seen that. So we felt like we were going to catch most of the ETV failures with that 1 year follow-up. And so you can see in this, and it's days from procedure. So if you look here, you're about at that 1 year cutoff. And although the shunt line continues to go down, so you have more failures over years 2, 3, 4 to 5, once you get to that 1 year follow-up, there were a few more kids that had an ETV failure, but it was very few additional ETV failures. So both groups had their highest rate of failure or return to the OR within the first 90 days from their surgery. And although the shunt patients continued to have more surgeries, at least at 5 years, they were pretty equivalent in their overall success regardless of the two treatments. So at 1 year, you can see a bigger difference. 60% of the infants with shunts had one treatment and were done. Only 35% of the ETV patients had one treatment. So 65% of them had to go back for an additional procedure. But at 5 years, it was still around 30 to 35% of the ETV patients. So very few additional patients had failed, but you'd had a further decline in the number of shunt patients. And if you follow those kids out with shunts, 10, 20, 30, 40 years, you continue to see more and more shunt failures. RJ?
Hi, can you hear me?
Yeah.
So I just wanted to make a quick comment. Looking at the numbers, it seems like out of the entire cohort, about 84% of the infants underwent shunt placement,
Yes.
compared to 16% for ETV. And then if we look at the mean annual case, we have around 26.6 for shunts, and 5.3 for ETV. So I think I'm wondering, maybe these places are maybe just not used to doing ETVs for these kinds of cases. Certainly we see more recent papers of groups that are, doing more ETVs that have maybe better success rates. So I just wanted to make that quick comment regarding maybe a sample selection bias, perhaps.
So there is some of that. This also, one of the other limitations so this was in 2004 to 2009, so there were not as many institutions doing ETVs. At academic centers, you'll find much more of a bias towards endoscopy in general in patients that utilize that, but in other community pediatric hospitals, there probably is more of that bias towards shunts. And then the other comment on this is because there is no ICD-9 at that time or 10 code for choroid plexus cauterization. We don't know whether these were ETV alone or ETV with CPC. And for infants under the age of 1, adding CPC does add significantly to your overall success.
Right.
Yeah.
Thank you.
And I think John had a question.
Yes, Dr. Sara. Regarding the analysis, it is said in the paper that with the multivariable analysis, there was no difference in the failure rate of both procedures. So I was wondering, what are your thoughts about it?
What were my thoughts about what? I'm sorry.
There was no difference in the multivariable analysis regarding the failure rate of both procedures.
Yeah. So looking at that when we're looking at sort of diagnosis or things, the biggest impact for whether the procedures were going to have an increased failure rate or not, like I said, was that age of their first intervention. And additional comorbidities of prematurity, IVH, or spina bifida did add to the risk of failure as opposed to a congenital, otherwise uncomplicated hydrocephalus.
Okay, I see. Thanks.
And then, and then Prakash asked a question about would you see different outcomes for the procedure if you take the etiology into account as well? And so when we looked at the prematurity, IVH, and spina bifida, and sort of looked at the failure rates, there was sort of an increased failure rate, but overall between the individual groups, whether you looked at shunts or ETVs, and all of these patients tended to fare better with shunts than ETV. But I think some of what we've talked about, both of these procedures have risk and have much higher failure rates when you're doing them in infants under 3 months than the children 3 to 12 months. So there is difference in the pathophysiology probably of some of that early hydrocephalus, but also in that early brain development. You do have differences in the development of your CSF absorption pathways that contribute to those high failure rates. And like I said, although the shunt failure rate at 1 year was 40% versus 65% for ETV, we don't know how many of these patients, especially given the time frame of this study, how many of those patients had the addition of CPC and whether that would help push things. And this was a much heavier shunt bias in the patient population than I think what we're starting to see now. And just kind of referencing back, these administrative databases are great for sort of trying to get a broad picture of disease processes across a country, because it does increase the power of your studies, but you are limited in what information and what conclusions you can really draw from that. So one of the other things we did to try and make sure that the administrative information that we were collecting was accurate is we had an internal database of all of our patients. And so we pulled the administrative data and then compared that to our internal institutional data as a way to confirm that we were capturing all of the patients with our search engine. So, any other questions, comments?
We have a couple questions in the Q&A box for you.
Have they? So yeah, I think I have gotten both of those. Yep. And yeah. So anything else?
Hello?
Yeah, RJ.
Hi. So I found a few papers where they did a combination of ETV and shunt placement, and some of them have reported better rates than doing either one or the other alone. I was wondering if you have any thoughts regarding a combination treatment.
Yeah, so we do see that. What I would usually say is I would try ETV, CPC in a lot of our patients, but then if it fails, then you can go towards re-exploration if the ETV itself is completely scarred over, you can always try and reopen it. But then you can go on to place a shunt. I think even if you have partially treated their hydrocephalus with ETV and the CPC, you're decreasing their overall utilization of the shunt. And I think that does help in the longevity of maintaining that shunt and that mechanical device if the kids aren't 100% dependent on it. And so even with the spina bifida patients, I think we're much more aggressive about trying ETV CPC than we were, 20 years ago when I was a med student starting residency. We were much more likely to put shunts in patients, and now I think we're much more likely to try endoscopy and give it a chance, and if it fails, move towards shunting.
Yeah, I see. It'd probably be a cool idea to sort of pull together a historical graph showing the trends over time, for the use of ETV, CPC versus the use of shunting, and sort of if there's a trend over time with one gaining more popularity or the other, or if there's any pattern to see from that.
Yeah, I could say, and I don't know that there is anything out there, and I don't think right now the HTRN has anything, but you also do see the pendulum kind of swing back and forth on some of these, and at least at meetings, what you do see is, although there was really a big push towards endoscopy, now we're maybe swinging back more towards, if endoscopy fails, moving forward with the shunt, at least when kids are in this infancy and in a period of brain growth and development.
Thank you.
Anything? RJ? Okay. Anybody else? Anything in the queue?
I think so far, no questions. I can, I'll just say that I think that was a great session, especially considering that figuring out how to do, traditionally more intimate sessions like Journal Club over a large virtual call is still a challenge. So we certainly gave you the hardest task of the 4 seminar blocks, and you've more than exceeded expectations. So thank you on behalf of the training center and all the faculty for putting this together. I'll leave the call open for another couple minutes if there's any lingering questions. But thank you very much for this great presentation.
You're welcome. And, I know you guys are not, with everything going on, not necessarily getting around to being able to do sub-Is, but you can see this is a picture of Charlotte. I know it's a different year for those of you going into your 4th year. So if there are any questions or anything you want to ask me, feel free to reach out. I'm happy to try and help you navigate this sort of unusual 4th year for those of you, or even, if you're coming into your 3rd year and trying to figure out the next steps for next year too.
All right. Thank you very much.
All right. Thank you guys. Have a good night.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.